So to provide the counterpoint, we'll hear from Dr. Edmond.
Thank you, Jenna, and thank you, Stacy, for inviting me and our awesome program committee for APOS this sub-day. So I have my work cut out for me. Obviously, I've already gotten voted down on not to image all children with ACE. I will call it ACE. Thank you, Dr. Gilbert, for that. It's easier to say. So my position is that do all children with ACE require neuroimaging? No, and I hope to move the needle on convincing you. And I have, it's like Shark Tank here. I have 4 minutes. I keep getting time cut back in sub-day to say things I need to say. So I've been given 4 times and hopefully 4 minutes, so hopefully I can do that. So you know what ACE is. The old associations were occlusion-related, decompensated esophoria microtropia, anisometropia, psychologic stress. If that was the case, we'd all be super cross-eyed. Moderate myopia, and of course, and some of the older Swan, Franchisetti, like these are ancient classification systems. I've got this time thing, this hourglass and the sunset. We really need to like revisit this. The associations or risk factors for ACE. Some of them include moderate hyperopia, like that's accommodative esotropia. I guess it does cause acute acquired comitant ET, but I wouldn't put it in this group. But in some classifications, it is there. But in the newer associations, well, we have a lot of, think of your collective experience. If it's not one of those things in the old association, how many brain tumors really have you missed? Probably not a whole lot. It's not a very common condition if you exclude the other old associations. So newer associations, gee, we don't know. It's something benign, idiopathic, because they didn't have a brain tumor and they didn't have Arnold-Chiari. So newer associations are brain tumors, as was pointed out by Dr. Gilbert. Pontine and cerebellar, one in thalamic tumor probably was not associated really. And Arnold-Chiari malformation, it's type 1. Remember, type 2 is like a different beast. These are kids with meningomyelocele, spina bifida, so we're really talking about type 1. So, first reason that you don't need to scan all children with ACE is intracranial pathology is rare. I know Dr. Liu, my inspiration in going to pediatric neuro-ophthalmology, is here, so I hate to not use his paper, but there was a nice poster, Dotan, a couple years ago, 20 healthy kids, no significant hyperopia, comitant, no indication of nystagmus, no papilledema, near ET slightly greater than distance, negative neurohistory and exam, 19 kids, 19 kids got neuroimaged, all normal. So they're like the benign idiopathic form of ACE. One refused imaging, but no symptoms in 2 years. The next study has already been quoted by Dr. Gilbert. Second reason to not image, because intracranial pathology is rare in healthy and even in unhealthy kids. So in the same study, 48 kids, 3 of them got MRI CT scans because they had neurosigns or symptoms. Like you're gonna image kids with headache, ataxia, papilledema, end-gaze nystagmus. They also had children in this group that had accommodative esotropia, and they also imaged less than 3 diopters of hyperopia. 3 imaged, 3 out of 48 all had intracranial pathology, as you would have predicted from their symptoms. And the most reliable indicator was distance greater than near esotropia. So the remaining patients without obvious etiology did not develop signs or symptoms of intracranial pathology over the long term. So they didn't miss anything. Third reason not to image everybody is intracranial pathology rarely presents as isolated ACE. Let's take the 2 intracranial pathology groups that we've talked about, Arnold-Chiari and brain tumor. So Arnold-Chiari type 1, it's pretty common. It occurs in 3% of the population. And a large percentage are asymptomatic. So look at this study, 51 kids diagnosed with Arnold-Chiari type 1 by MRI. The radiologist looked at thousands of scans, found this group of patients, went back to determine what their presenting symptoms were. Headache on the leaderboard. And this is a headache that is cough-related or Valsalva-related. Very suggestive of clinically significant Arnold-Chiari. So On the leaderboard, we have headache, neck pain, vertigo, upper extremity numbness, ataxia, upper extremity weakness. Where do you see ACE? Nowhere on here. This is the largest study. So what about the brain tumors? I see them all day long. I feel like I'm a neuro-oncologist. So what are the most common signs and symptoms? It's not isolated ACE. Most common signs and symptoms for Pontine, cranial nerve 6, cranial nerve 7, gaze palsy, long tract signs, cerebellar tumors. On the leaderboard is hydrocephalus, papilledema, 6 nerve palsy, and ataxia. So if these symptoms are not initially present, they're going to develop soon. And you know that diffuse infiltrating pontine glioma that you're freaking out, that you're missing, they all, unfortunately, the treatment has not improved in 30 years, and they're usually, it is always fatal within 6 months. So in conclusion, neuroimaging is not indicated in all children with ACE. Most cases are in the benign group, the idiopathic group, and not secondary to intracranial pathology. Neuroimage these kids: abnormal eye exam, end gaze nystagmus, papilledema, distance greater than near esotropia, and of course a 6 nerve palsy. Image abnormal neuroexam or history. It's easy to ask about headache, and a headache with a brain tumor is typically global, or elevated ICP headache is in the middle of the night or on awakening. Arnold-Chiari is with cough or Valsalva. Ask about neck pain, dizzy, ataxia, upper extremity numbness, weakness, hemiplegia, hemisensory, and follow these children. Follow the non-imaged children closely for development of abnormal eye exam or abnormal history. Thank you.